I want to welcome everybody to today's Harm Reduction 101. Thank you all for being here. This is a very important event today, one that we've been working very hard to pull together, and we have an amazing panel and participants. So again, thank you for being here. One of the reasons we feel so strongly about this event is that drug deaths in Maine in 2021 topped 600. That was a 23% increase since the year 2000. It's, unexplainable and something we can do to make some changes. People who are using drugs or have struggled with substance use don't deserve to die. And, we know that Jesse Harvey, who worked very hard to be a person in recovery and an advocate, died in 2020, and he was only 28. So such losses are preventable, or at the very least, they're reducible, and they're certainly tragic. So we're here today to talk about harm reduction and risk reduction and how we can all together, all of us, work together to make a difference. And we have a marvelous panel, and we have all of you here from multiple different professions. And I just want to let you know that we will be putting the learning objectives for today's session in the chat, so you can take a look at them. Next. So we're very aware that today's content may activate people because everybody knows someone who's experienced substance use issues or problems, and many of us have people close to us who may have died or may be struggling right now. So we have counseling folks here available to you, and if you would like to identify yourself, I see Lacey, you're here, and I think Jen O'Neill was going to be here, but she's going to be here a little bit later. Autumn Straw, can you identify yourself so people know where you are? Rebecca Diggins. And as we go along, if anybody needs to check in with those folks, please feel free to do so. And we will remind you again at the end that folks are available to you. So now it's my great pleasure to ask our panelists, Zoe, Kinna, and Bob, to introduce themselves.
I guess I'll go first since no one else unmuted. Hi, everyone. I'm Zoe Brokus. I'm the Director of Operations for the Church of Safe Injection, and I've been doing harm reduction work in Southern Maine since 2010. So I'm really happy to be here. Thanks.
I can go next since my picture is next. I'm Kinna Thakarar, an infectious disease and addiction medicine physician at Maine Med, and like Zoe, very excited to be here on this panel. So thanks for having me.
Good afternoon, everyone. Bob MacKenzie, Chief at Kennebunk Police Department. I've been chief here for 13 years, but been with the department for 33 years. Very active around the work of substance use disorder. I'm also on the board of Milestone Recovery in Portland, the board of United Way of Southern Maine, and also in Kennebunk Rotary. So again, thanks for having me.
Yep, we're going to start with a poll, and the way to access the poll is to scan the QR code with your phone. It will take you to the website, or if you have Poll Everywhere already on your phone, you can enter CECE 2021. And we're interested in hearing from you what you think of when you hear the term harm reduction. Safety and prevention are showing up well, which we like to see.
I like that safe is really powerful in the middle there. And justice is in there.
I'm also just really struck at how different these look than they did even a couple of years ago when we first started experimenting with Poll Everywhere. There's a lot more words here, and it just shows that there's a lot more knowledge and a lot more education happening around harm reduction in general. So that's really great.
Thank you, Zoe. And although we're focusing today on substance use disorders and specifically, we also want to remind everyone that there are other kinds of issues where harm reduction is a methodology that we can use to reduce risk and improve people's overall quality of life.
It's a great way to understand what our audience understands about harm reduction. And I think we're going to have a great conversation going forward based on the results of this word cloud.
Yes. Well, thank you. And I think maybe we'll hand it off to Kinna for her presentation. So thank you and welcome.
Great. Thanks again for having me. And yeah, I think it was very encouraging to see all the thoughts in the word cloud. Like Zoe said, I think we've come a long way in the past few years. So it's fantastic. So yeah, as you heard, I'm an infectious disease and addiction medicine doc, and I also do research and partner with community organizations around harm reduction. And I'll be talking a little bit about, the perspectives from a health professional. The next slide. So what is harm reduction? So it sounds like most of you, based on the word cloud, probably have some idea, which is, again, fantastic. And, we think about ways to reduce harm in life, right? That could be wearing a bike helmet. That could be wearing a seatbelt. These are both ways to prevent harm in a very practical way. And when we think about harm reduction in the context of substance use, it's very similar. We're trying to reduce harm, quite simply. And if you just want to click ahead, when we think about harm reduction, specifically, I really like this definition, which is from the National Harm Reduction Coalition, which is that harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. So harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. So, harm reduction in the setting of substance use, yes, it's reducing these harms. But what differentiates it from, wearing bike helmets and seatbelts is that there are decades of work being done by activists, by people who use drugs around harm reduction. And so that's really, I think, what sets it apart from these different strategies that we think about, like bike helmets and seatbelts. So what does harm reduction encompass? So, a lot of people, when they think about harm reduction, the first thing that comes to mind is needle exchange. And I think we'll probably talk about this a little bit later, but we are kind of moving away from the term needle exchange programs because, it's more than just exchanging one needle for another. It's about connections. It's about providing wraparound services. And harm reduction really encompasses so many things. It encompasses distributing naloxone, which is, a life-saving medication to reverse overdoses. It does encompass, giving someone a clean needle or syringe when they need it. But it also is very much about peer support, community mobilization. Again, syringe service program, staff workers making contacts with clients and linking them to care if and when they're ready. It's about having very low barrier drop-in spaces. And what does low barrier mean? That means, you don't have to make your appointment 7 days or a month in advance to show up at your doctor's office. There are spots where you can go and get treatment, same day treatment, whether it's in the emergency department or a clinic. And then there's supervised injection facilities, which I think we'll have an excellent conversation about this later. But for those who aren't familiar with supervised injection facilities, which are also known as safe consumption sites or overdose prevention sites, they are safe places where people can go to inject their pre-owned drugs. And these have been adopted all around the world, including, starting in Australia, Europe, Canada. We got our very first one here in New York City just this year, which is super exciting. They've already reversed almost 100 overdoses. It is not yet legal here in Maine, but this is definitely part of harm reduction. And they've been shown to reduce overdoses and infections. Harm reduction also encompasses legal support and policy reform. I think we'll also talk about this a little bit later. All of us, can do our parts to help change policies and really try to help promote harm reduction. The next slide. So you might ask, why is an infectious disease doctor even care about these kinds of things, when there's a lot of other stuff going on like COVID? Well, I work in a hospital, and most of the patients we are seeing at the hospital these days are being admitted with infections related to injection drug use. So this can be endocarditis, really serious heart infections, epidural abscesses, joint infections, And these account for, oftentimes 50% of the patients that we're seeing at the hospital. And as an ID doc, I'm part of actually the Infectious Disease Society of America's task. We have a national task force specifically that has made recommendations to prevent and treat these types of infections. So it's something that you're going to see regardless of what discipline you're in, whether you're working on the inpatient or outpatient side. We are seeing rises in infections related to substance use. Next slide. So this could be, we're kind of joking before this could be a whole talk in itself, reviewing what are these strategies to prevent infections and treat infections. We've left, I think, we have some resources at the end of this, and I left some references at the bottom of the slide, but these are just a few of the strategies that we know really work to prevent and treat infections. This includes treatments like medications for opioid use disorder, buprenorphine, methadone. We know these things work. Also syringe service programs, which I'm sure Zoe can speak to given her experience as well, but they've been shown to be very effective in counseling people and linking people to care, giving vaccines and supplies. They also review, safer injection practices and safer use practices. Also, we know that vaccinations, Hep A, Hep B, tetanus, all these things obviously can prevent diseases, and we want to vaccinate people whenever we see them, whether it's at the syringe service program or in our clinics. We also know that screening people for sexually transmitted infections is very important. And also can reduce the burden of some of these diseases we're seeing. Again, supervised injection facilities, like I mentioned, and we'll talk about in later in this chat as well. The pictures on the right are actually 2 photos of the site that I visited in Toronto a few years ago. And it was really fantastic to see how well run these facilities are. Another strategy is pre-exposure prophylaxis for HIV prevention and housing, which was last on the list, but really the most important. Other things, this is just a quick photo of some of the harm reduction equipment that people just, maybe distribute at syringe service programs. I'm sure many of you may be familiar with this equipment if you volunteered at the exchanges, but this is just a photo of some of the things that you might see syringe service programs distributing. Next slide. And, why is it important to distribute things like needles and syringes? Well, if you look at the photo on the right, it's a photo, this is from AHOPE, one of the syringe service programs in Boston, where it shows if you reuse a needle after just a few uses, look how, blunt and curved it becomes. And it is not surprising that our patients end up developing infections and other complications from not having enough clean equipment. And the picture on the left kind of goes over, safe spots for people to inject. And there's, a lot of counseling that goes on rotating sites and how to inject safely. Next slide. And finally, integrating harm reduction into practice. What can we do? Next slide. So, and I won't spend too much time on this because I think Zoe's digging into this, but just knowing that people who use drugs really do encounter so much stigma, and it's really important that as health professionals that we recognize that and we do our best to try to reduce this stigma, because a lot of people wait until the last minute to go to the hospital because that is the last place they want to be oftentimes. Next slide. So again, I won't go into great detail or steal Zoe's thunder, but generally, I think just recognizing that language matters when we talk about substance use, and I have terms to avoid on the left and recommended terms on the right, really using person-first language, using this when you are documenting in the clinical records and talking to patients. I can't tell you enough, I've spent hours just trying to change the language in some of the notes that I see in the hospital. So this is really important and a low-hanging fruit, I think. Next slide. And again, I won't go into great detail, but we've tried to standardize a way to really optimize health and safety for people who use drugs and thinking about harm reduction. This is a checklist that we use on the inpatient side on the infectious disease consult service all the time, talking about, okay, this person's being discharged. Let's make sure they have naloxone. Let's make sure we've talked about safe injection, giving them, hepatitis C screening and referrals to care, et cetera. So this is just an important way to think about systematically when you're on your clinical rotations. Next slide. And then also, encouraging the use or prescribing naloxone. And I like this, comparison, just thinking of naloxone, again, which can reverse an overdose, thinking of it like a fire extinguisher and really normalizing it. I just tell people I carry naloxone in my own bag, which is true. I have one in literally every bag that I carry. And so really just trying to destigmatize, things like this is helpful. Next slide. And how can you learn more about harm reduction? Well, I mean, I'm sitting here as an expert talking about harm reduction, but really the experts are people who use drugs. That is how I learn, talking to community partners. Of course, there's addiction medicine training and conferences. We now have addiction medicine fellowships. Please feel free to email me if you're ever interested in getting some additional training. There's all sorts of courses, and we have a Project Echo through Maine Medical Center. And I just encourage you to reach out to our wonderful community partners throughout the state. Next slide. And so just some take-home points from my perspective. Again, just remembering harm reduction it's really a social justice movement that's started by people who use drugs. It's really just meant to use non-judgmental strategies that are practical to reduce the negative consequences from drug use. Really thinking about how to promote harm reduction in your own clinical practice. And again, the low-hanging fruit, I'd say, is really thinking about the language that we use and also prescribing naloxone. Those are two very easy things, I'd say. Next slide. And okay, I will turn it over to Bob here, who will take it away and hopefully discuss some of these harm reduction strategies. And Bob, actually, I would be curious, if you don't mind, just to weigh in on some of these strategies, specifically supervised injection facilities, because I think this is something that's so new to the US, I'd say, and just your thoughts on that from your experience.
That's a good setup. I'm sure everybody would love to hear what I think about what I know of safe injection sites. And many years ago, I'm gonna go back probably 8 years or so. I was part of Coastal Healthy Communities Coalition through the University of New England, and I was sitting in at a meeting. And after the meeting, one of the guys that was there was Matt Brown, who went on to med school, but he was really big in obviously the recovery areas and recovery himself. And we stepped outside and he says, I have a question for you. What are your thoughts on safe injection sites? And I will say the hair on the back of my neck stood up because I was like very conflicted. It just hit me. I'm like, geez, I don't know. And one hand, I'm thinking that's illegal. If I know illegal things are going in here, I mean, look what I've been doing for 33 years. That's not right. That's not legal. How can I? But at the same time, again, I was very much doing some recovery work. So I was very conflicted. So again, many years has gone by since then. I've learned a lot, and I've worked with a lot of people in recovery, and people that aren't in recovery as of yet, but people that are doing really good work. And the bottom line is they're human beings, whether it's a loved one or like I said, somebody that I've worked with. If I were to say, where would I want somebody to use? As we know, many people that use alone. And that's why we have a lot of fatal overdoses. So if given the opportunity, why wouldn't they go to somewhere where it's safe and supervised and also have the support where people can potentially help them get into recovery? So I would say that's where I stand. But yet at the same time, I'll be honest. Am I going to come out tomorrow and say, I want a safe injection site opened up here in Kennebunk? Because there's a good chance they may be looking for a new police chief. And why is that? It's because people aren't educated around it enough. And what I found is once you start to educate people and they understand, they open their ears, they open their hearts and their minds, and they're more open to this. So again, I lean on the side of being certainly in favor of safe injection sites to keep people safe, certainly. So, other harm reduction tools. I know we're going to go into it more. We've talked a little bit about language. That's huge. And being in law enforcement, I'm guilty of it back in the day. Again, 33 years of doing this. I've heard everything. Dirtbag, scumbag, druggie, addict. And now, you put a loved one in that space, Is that what you want them called? No, absolutely not. The family support is very important as a harm reduction tool. Once you educate families on how they can be supportive, they can play an intricate part of somebody's recovery. There's community education and naloxone training that was already mentioned. I run here what's called the Kennebunk Area Response to Substance Use Disorder, and that's bringing 3 communities, Kennebunk, Fort, and Arundel, underneath the umbrella of RSU 21. But where we've brought all the stakeholders together, it's about 40 people on the steering committee that we've identified, what are the issues surrounding substance use disorder? And even more importantly, where are the gaps? What do we need to fill in those gaps? And what I find is that brings all of these stakeholders together on the same page. We're all educated the same way. And now we're working together as a group. And that includes people that are in recovery to fill in those gaps. And all of the things that we are doing is definitely a harm reduction philosophy here. Law enforcement training, building relationships. When you have law enforcement that are working with our folks that maybe are not in recovery yet, but are working with them and treating them as human beings, maybe offering them a fentanyl test strip, which obviously is a harm reduction method. What you're doing is you're breaking down barriers between those that you may be using and law enforcement. Think about this, when a police officer talks with somebody that they know is using maybe opioids and says, you know what, I care about you and I don't want to see anything bad happen, and then we have these fentanyl test strips, I want to give them to you. That person's like, whoa, wait a minute. A police officer is giving me something that I can use to test my drugs. I mean, that's pretty significant. And once again, that's another harm reduction tool. As I said, I worked with a lot of people in recovery. And one thing that has stood out in many of those people's minds are police officers that treated them with respect, dignity, and treated them as a human being. And those officers stood out in their mind. And so law enforcement obviously has a lot to do with regard to with the harm reduction. And if I can go back just a couple minutes with regard to either needle exchange or safe injection sites, I want to bring up something that was very interesting with regard to Rotarian, who was our district governor, who actually came down with an infection that went to his heart, myocarditis, I believe, is that the term. And he was at May Medical Center and needed open heart surgery for that. So he was in for quite some time. But at the same time, I was up at May Medical Center presenting a class on basically harm reduction, education around substance use disorder, and naloxone training. And he told me while I was there, he actually was able to come down to this training in a wheelchair, that he was there because of this infection. At the same time, there were 39 other people admitted into Maine Medical Center with similar type infections, but those 39 other people were there because of intravenous drug use. And that said to me, wow, first of all, it's we need to do something differently because we need to save people's lives. We need to save them from getting these other diseases and infections. But think of the financial impact that has on all of us. So when I talk to community members around safe injection or needle exchange, I bring that up because if they don't think they care at that point about people and the human element, they certainly care about the financial aspect, where it hits them in the pocket. And you can certainly go a long way with that. I think at this point I could go on all day, but I'm going to turn it over to Shelley.
Well, thank you, Bob, very much. And the next thing we want to do is to put you in breakout rooms and to give you a case and to give you some prompts and to have you have a conversation about this. So this is the case we've put together. Caitlin is a college student. She's always been high functioning, a loving daughter, and a good friend. However, recently her family noticed some changes in her typically upbeat personality and appearance. Subsequently, Caitlin was arrested 2 times for possession of non-prescription pain medications. This came as quite a shock to everyone. So here are your prompts. first of all, introduce yourselves to each other because you may not know who's there, and it's really good to have a sense of who's in the room because this is a very sensitive topic, and we want to create as much of a safe space to have a conversation as we can. And the first thing is, what are your initial thoughts and impressions of Caitlin? And try to be as open as possible. How might you address her health needs using your professional training and expertise? What barriers might you face in connecting or engaging with Caitlin, given the situation that she finds herself in? And who else do you want to work with to help Caitlin and to be on her team? And these questions are in the chat. So we invite you to come into the chat room and have a conversation, and we will be there for about 10 minutes or so, maybe a little longer. Let's get those breakout rooms going. Lee? So I think we have everyone back now, so I think I'm going to pass it on to you, Bob, to help us with the debrief.
Okay, thank you. So I was able to join 2 of the chat rooms. I did miss the first couple of minutes only because this breakout rooms was kind of new to me. So navigating to it was a little tricky for me at first, but I heard some great conversation as far as the barriers that, as far as health insurance is a barrier, the district attorney's office, how do they look at folks that are arrested? Do they want to throw the book at them, or is there a drug court or anything? I heard a lot about, support. What type of support was there? Was the family involved? Talking to her friends. Something else I heard: resistance to get help. I think that's important, because are they ready to get help, right? Law enforcement, with how was law enforcement with her at the time of the arrest? Did they try to help, or was it just, the standard, throw the book at them, take them to jail? And I heard family disease, and I think that's pretty important, because it's not just one that's suffering, it certainly is the family. I don't know if any of the other panelists want to bring up anything before we go into the next slide, but I'll give that opportunity if that's okay.
So, Bob, I just wanted to add from our group, I was so struck by people's compassion and, empathy and willingness to be with Caitlin and her struggles. And it was very moving, I have to say. I know, Jen, you were in the room too, and others. It was incredibly powerful experience. And I also want to make sure we check in with folks in the Biddeford campus and on the Portland campus if anyone wants to chime in from our actual physical spaces on our campuses with some feedback.
Yeah, Shelley, we are in Portland, so these folks have been having a good conversation here. Who'd like to summarize? Anyone? Okay, hold on here.
Sure. Hi, I'm Zach. I'm a first-year PA student. I worked in EMS for 6 years before came back here. One of the points I just wanted to make is that this vignette, I think, paints a picture of somebody you wouldn't necessarily expect without much training or healthcare experience. And I was talking to my group, and I brought up this story when I was in Metro Boston. We had a day in 2017 where we had 3 overdoses in a row, and one was an 18-year-old high school student. One was a 75-year-old woman at an assisted living who had too much pain medicine, and the last one was a 35-year-old businesswoman. And none of those people, at face value, you would necessarily expect as a layperson or someone in the public realm. I just think there's no one picture of substance use, and I think we should all have a, just higher baseline awareness of that, and always be looking out for that in the way that we look out for, domestic violence or trafficking, things like that always exist under the surface, but we don't think about every day.
Thank you so much, Zach. So my name is Belle. I'm a second-year social work student, and we had a really robust conversation here in our group. We had PA, OT, PT, and social work represented, and as we thoughtfully advocated for our client, Caitlin, we thought about, we divided the conversation between chief complaint, so why in any situation we might be seeing Caitlin, and we thought about long-term care. So Caitlin is coming to us for this situation, and she's seeing us as potentially a college student who might be underage, but also as an 18-year-old who is transitioning to college life during the pandemic. We're also potentially dealing with her family, chosen or biological, and those that also care about her. So there are these long-term systemic systems that she's encountering at college, but also in her day-to-day life. We talked about physical injury that might have encountered with her substance use. We talked about the fact that she might not even see her substance use as a problem, and so really allowing her the agency to tell us why she is seeing us. Then we talked about the fact that there might be underlying trauma or other issues that have not surfaced yet, and for all of our disciplines to really benefit her and her long-term care, how do we work together, but also let her drive what her needs are. And so I think it really led the conversation around the case and to let our assumptions kind of take a step back and see what Caitlin needed. And we all know, and I think Zach spoke to it really well, that there are lots of Caitlins in the world, and unfortunately, this is like the raging opioid epidemic within the pandemic. It's like Russian nesting dolls. And so we tried to be really thoughtful about that we are limited by our scopes of practice and our education, but trying to thoughtfully work together to unpack what we're presented with, and that we might not always have all the information at hand, and how do we obtain that?
Thank you. Thank you. Shelley, you want to go back? I'm wondering if it's possible to go to the first slide. We had the two women back to back there. Okay. So let me tell you a story here. The girl to your left, dark hair, is my daughter, Kristen. The girl on the right is my daughter, Caitlin. And this was taken while she was in college, Salve Virginia University in Newport, Rhode Island. She was an honors student in high school, made the dean's list at Salve Regina. And again, I've been doing this work for a number of years. In fact, both my daughters were in a movie, Point of No Return, which is all about underage drinking and the consequences thereof. She was always on the very straight and narrow path, but in her college years found some issues. And if you can go to that next slide. So that was my daughter, Caitlin, when she was arrested coming out of Lawrence, Mass. Now, just what precipitated this is I did see some signs even while she was in college. One of the first things of note was she was on my insurance and she was on her mom's insurance as well. We had two insurances, very lucky. However, what I started to get was the EOBs, explanation of benefits, several of them. And I talked to her mom saying, I'm a little concerned about this. And I talked to Caitlin, and it was always something happening with her. It was like she's having a stroke of bad luck. But I was getting really concerned about it. When she was back home from break, I would start to see some signs with regard to potential drug use, which concerned me. I talked to her about it, and she denied it and said she'd never put anything harmful in her body. It got to the point where I was so concerned. I talked to her mom and her sister, other loved ones, with regard to what to look for, because I started to be concerned there could be opioids on board. And it came to a head at a funeral, actually, we had gone to. And when I was there, it was a family funeral. I didn't see Caitlin there until I left, and then she went in. And shortly after I left, within a half an hour, my other daughter, Kristen, called me. I said, Dad, something's up with Caitlin. She kept going in the bathroom, drinking a lot of water. She was sweating. Her pupils were pinpoint. Right then I knew what she was dealing with. Now we're going back, about 5 or 6 years now anyway. I wasn't all up on stigma as much as I am now. The first thing I did is I texted my daughter Caitlin and I asked her, so are you ingesting it, or are you snorting it, or are you injecting it? And she said, I don't know what you're talking about. I said, the heroin use. She says, I'm not doing that. I said, I told you you're dancing with the devil. I said, if you don't get help, you're going to die. And I want to help you. That just pushed her away from me. And she did stay away from me as much as I tried to reach out. So I talked to her family about support, what we could try to do. And unfortunately, she was away at the time. She didn't need any of our help. And then the day came when that mugshot came to be, and she was arrested. And I breathed a sigh of relief, because I knew at that point, how could she deny it? This was a good turning point for us. Well, I will say she did a hell of a good job denying it. However, she did agree to go to treatment in Chicago. I got a professional interventionist, and we sent her out there, and she did extremely well for the full time that she was out there, almost a month. And I will say, when she got back, I wasn't completely convinced she was ready for recovery, even though she had just gone through some recovery and detox and whatnot, because she was very private. She didn't want anybody to know about her use. That concerned me, because I was working with a lot of people that are in recovery, and it was just different. Within a couple of months, I started to see those signs again of use. I talked to her about it. She denied, and then she stayed away from me until the second arrest came. I will say it's been, that was probably 2.5 years ago. She went into recovery herself that next time. She went into IOP, intensive outpatient treatment, and it was totally night and day. She was willing to talk about it. It was okay for others to know. She is now 2 years, almost 2.5 years in recovery. She works along with me, speaking engagements. She's been in the newspaper. She's been on the broadcast news. She's in the Kennebunk area response to substance use disorder group with me, and lends her ear, and she's willing to talk to anybody just to help others. So I'm proud of her and what she's done, but she did have the family support there, but at the time she didn't want it. But what she said now is that family support she knew was there. And when she was ready, she depended on it. And we certainly helped her through that. Massachusetts did not throw the book at her twice, even though she was arrested twice. And I had no impact on this whatsoever. I stayed out of that. But they really only had to do like a year worth of supervised release, which you have to go check in with a probation officer. And if she went into recovery and did her programs, then those cases would actually go away. And so that's been great for her. But it is night and day difference from where she is now than where she was. Again, I've been doing this work for a long time. This just gave me more passion to do what I'm doing. I know what I'm doing is the right thing, and that's why I get other law enforcement throughout Maine and across the country on board with us as law enforcement being advocates and allies instead of just always throwing the book at people. So at this point, I'll pass it on. Thank you.
Thank you so much, Bob, for sharing that story and for, enlightening all of us. Many of us have been touched by family members. Some of us here may also be in recovery or have children or parents in recovery as well. So your story really lends a very shining light to what we all need to be part of. And so now I'm very, very pleased to introduce Zoe Brokos, who is going to take us on a conversation around language, stigma, and recovery. Thank you, Zoe, for being here.
Thanks so much for having me. And I really appreciate everything the chief was just talking about. I put in the chat, but I'm pretty sure that he and I did a training shortly after his daughter had been arrested. And, you could just see the way that the work that he was doing in the recovery community and the harm reduction community really helped support him on this path with his family. So it's really beautiful to hear that story. Next slide, please. So we're going to talk a little bit about language and stigma. And I really think that the medical community and the future providers in our communities really have an opportunity to have a huge impact on people who use drugs and people who are in recovery. We've made some great progress here in Maine. And we've done things like this, where we've replaced certain words in our laws and in our rulemaking, and that's really important. And we've seen huge shifts. I mean, even just listening to students and people talking today, just the different way that people are talking about this is pretty significant. Next slide, please. So I'll just let you look at this definition when we talk about stigma. It's really important that we know what we're talking about. So, this is the definition for stigma. And then next slide, please. Let's also look at the definition of recovery. And sorry, I'm looking at my notes as we go because this is a new slide for me. But yeah, this is the SAMHSA definition of recovery. And you can kind of see how these two definitions can walk alongside each other and can also be problematic. So I believe next slide, please. We are going to have you think about the word stigma, and in one or two words, just describe how the ways in which people with substance use disorder specifically are often stigmatized. So we'll take a couple minutes. So it looks like weak is showing up quite a bit. Criminalized, bad.
I think there are a lot of assumptions in here too. Presumed guilty, forgotten, bad family. So a lot of assumptions that go in when we think about stigma and stigmatizing words.
Yeah.
Flawed.
Unintelligent, I think, and when we think about specifically stigma in medical settings, I think what I've heard a lot is people who have stories of medical professionals talking down to them, making assumptions, telling them what they need because they think that they don't know what they need. How could they?
Yeah, that's a big thing. I think having, being on that side in the hospital, that's come up a lot, and people really want to know their options of treatment, even if it's not the most effective type of treatment, but what's best for them, and having that option and not being perceived as unintelligent or not understanding things.
I think you see that in a lot of settings too, not only medical and health settings, but in schools, even, within the social work and counseling professions, that there is a lot of stigma attached to families where substance abuse is an issue.
Yeah, somebody just put in the chat about these folks are someone's daughter, sister, and friend. Obviously, I have spoken to that, but I remember getting back to law enforcement, me first bringing up Narcan training to our department. This is well before my daughter had her run with a SUD, but I remember one of the officers actually saying, why would we want to save them? I was floored, and I was not happy with that response whatsoever. And that's exactly what I said, that these are someone's, brother, sister, son, daughter, husband, wife. How treat them like a human being. It's a human being. And I'm happy to say since then, our officers have come around 100%. But it's that stigma is so real and so hurtful.
Yeah. Absolutely. And it really is, drug use is such a continuum, and that's a talk for another day. But again, thinking about the opportunity that providers have in the community to be a positive person in someone's life. There are plenty of people who use drugs very safely every single day, but would never admit that to their doctor because exactly of this reason. So how can we expand, not just thinking about drug use as always being somebody who's dependent on substances and completely debilitating. We also need to provide education and support to people who are using drugs recreationally and might not know certain risks that are potential. Are we ready to? Okay, great. So, really thinking about how stigma has gotten in the way of people accessing the things that they need. And I'll kind of let you look at this slide while I talk about this, but I think that we have seen a lot of improvement, but we still hear of prescribers of people who are using medication for opioid use disorder. There's still a big conversation around tapering there. That feels like judgment. That causes stigma right there. Or people not being honest and open about the fact that they're injecting, when, as we know, there are serious conditions that can occur if somebody gets an infection and it goes untreated. And then when people do want to talk about recovery resources, I've known of a lot of doctors and health professionals who just don't know about the resources in their community. And that can be such an incredibly important time to build trust with somebody by just having a conversation about the resources that are available. So we know stigma is still very prevalent because we're still hearing about it every day from people who use drugs and people who are in recovery. Next slide, please. And this stigma runs deep. And I think, there's a lot that can be done in thinking about how you can advocate for your patients. Allowing them to decide what works best for them is really important, and being really mindful about the way we're talking about it. I think we've done a good job. People know that we're saying substance use disorder. I like to take it one step further and sometimes just refer to it as substance use, because we don't always know if somebody considers their substance use disordered or not. I like substance misuse a little bit more for that reason, because I think disorder still has a negative connotation. But it's really important to find ways to talk about their use in a way that feels comfortable for them. So allowing them to lead that conversation, but also really listening to the way that they talk about it. Let's not assume that the individual sitting in front of you is deeply dependent on opioids if you don't even know what substances they're using or what their use looks like. Next slide. And we hear this in the public all the time. And whether it's conversations about syringe service programming or overdose prevention sites, also known as safe consumption sites or safe injection facilities, there's still a lot of misinformation and people who just don't understand, and maybe they haven't been directly impacted by substance use in their life, or maybe they have. I think I've seen it go both ways, where sometimes people who do have a direct experience, they use that experience as kind of the blanket for all things. And so really being mindful of how we talk to people about. I really liked what one person said, and I wrote it down, because I think that idea of support systems and chosen or biological family is such a triggering thing for some people. So let's not immediately ask somebody, hey, is mom and dad involved? Like, family is what we make it, and family can mean many different things. So finding ways to engage with people where it feels open and it feels inviting. And that's referring to somebody, not as an addict, not as somebody who, is addicted to drugs and it needs to be led by the person, and allowing the person to say, I'm a person who uses drugs. I'm a person in long-term recovery. And this is what it means for me. I think asking goes a long way too. Next slide. Oh, the media. So for anyone who's paid attention to the newspaper or the news in the last decade, I find it absolutely appalling that we continue to see these images of needles and pill bottles and people on stretchers being wheeled into an ambulance. That is not helping anything, in fact. And so there's a lot of advocacy being done right now in Maine, that whenever there's a news report on something regarding substance use, we have a lot of follow-up conversation with the reporters and the media stations about the images that they're using. It really, really impacts the story, and can really misrepresent what we're even talking about a lot of the times. I think we see that with needle exchange programs. I mean, anytime I see needle exchange program on the news, there's then images of needles in the grass, unkept needles, needles in someone's hand, sometimes even like needles like being injected. I mean, there's a lot that we can do here around the images and the way that we talk about this issue from the media. Next slide. I'm not gonna talk to this slide because I don't like to talk through slides, but same kind of thing. Okay, so this I think is really important, and I think that this is still very new, and so there's a lot of room. I think we're still seeing this change around a lot. But it's very, very common for somebody who has a history of substance use or is actively using to refer to themselves as an addict or a junkie. And if that's the language that they want to use, that is their choice. We obviously will not be using that language. And I also don't think it's our job to correct them. I think maybe once you build up some trust and maybe build up a relationship, you can kind of explore that. But again, we don't want to treat people like they're unintelligent or they don't know what they're talking about. This is their life. And if they want to use that word, they can use that word. Thinking about negative and positive when it comes to specifically toxicology testing, UA testing, really important. And we hear people say clean and dirty all the time. Again, usually about themselves. Oh, I've been clean for 5 years. Oh, I tested dirty last month. Again, we just want to make sure that as providers and as people in the community, we are using language that's empowering and non-stigmatizing. So I think that there are a lot of things that providers can do. I think number one, being mindful about the way you're taking notes, the way you're talking about patients, their medical record is forever. And so what you put in there is really important and makes a really big difference. I also think that providers have the ability to connect people with resources, and that can be the foundation for building that trust. Asking somebody if they want naloxone or asking somebody about resources in the community when they've disclosed that they're injecting drugs can make a huge difference for somebody who might not have any idea that you know what's around, or they might not even know what's available to them. So offering naloxone, if someone has questions about medication for opioid use disorder, having resources and a good understanding of what that means. Also, I said it before, but this conversation about tapering, we really have the opportunity to have our medical community lead that discussion. I see a lot of concerning things that happen in recovery residences or in intensive outpatient programs where they're making decisions for clients or for patients without the involvement of the prescriber or somebody from the medical community. So really talking that through about how we cannot rush people through treatment because it is what makes us comfortable. Some people are not going to be ready for treatment for many, many years. Some people will prefer an IOP program over residential. Some people will want a medical detox. Some people won't. And then there's a large number of people who will want resources that we don't have available to them here. And I think that can be one of the hardest parts, is when somebody is ready to explore treatment and we don't have what they need here in Maine. Either their insurance doesn't cover it. We have a serious lack of medical detox options right now in Maine. And COVID has also made everything much more difficult. So a lot of group setting treatment programs are happening virtually. You know, there's a lot. So recognizing that those of us in the community, whether we're doctors or dental hygienists or nurses or social workers, there is an opportunity to engage in a discussion in a way that can really help that person feel safe. Kinna mentioned it, but talking about vaccines or, talking to people about testing regularly for hepatitis C and HIV. And I mean, every single person, we can't just be offering some of that stuff to people because we think they're at risk. Also, when we think about naloxone, having a broader view of who we're offering naloxone to. We're dealing with contaminated drugs here in Maine, and almost everything that people are buying on the street has the potential to have fentanyl in it. And so making sure that we're offering naloxone to people, whether they are using opioids or not, really making sure that everyone has access to it and knows exactly how to use it can be really important. Another thing that I think we forget about, and this is less common, but sharps disposal discussions. We see people in syringe service programs here in Maine who have diabetes or have some other medical condition that requires a syringe, and they have never been properly counseled on disposal. So making sure that every single person who either is using substances and has disclosed that they're injecting drugs, or somebody who's using syringes for other reasons, making sure they know where they can access sharps containers. That's something that I feel like is not talked about very much. And then I think the other thing that you all can think about, especially right now as we have a lot of advocacy work happening in Maine around legislative bills and different things that are happening specific to substance use, is really using your voice and your experience and your education and knowledge to do something like write a letter to the editor. Get involved in an advocacy group. Find ways that you can kind of help bring awareness to this issue and continue to model that non-stigmatizing language. The more we say it, the more we talk about it, the more we write it out. I think that there's a lot that we can really do to kind of move things along and move it away from this idea that everyone who uses drugs, is weak, is bad, is a stereotype, is unintelligent. And I think that kind of these words here are the beginning of it. But there's a lot farther we can go, and talking to people about their drug use and what it looks like for them is a really great place to start, as well as doing some of these larger community activities that you can engage in more people and learn from other community members, and use your voice to really help us make a difference.
So Zoe, thank you so much. And now we do have some questions, and Elise, you've got some questions from the chat. And I also want to make sure that if folks have questions for a panel, either we go, in Biddeford or in Portland, or if you want to raise your hand, go ahead. But Elise, I know you have some questions. So would you like to pose those?
I do. So just talking about how it's important to create a community when we're talking about harm reduction. This is open for any of the panelists, but can you just explain how harm reduction promotes dignity for individuals in the recovery community?
You can go for it first, Zoe, if you want.
I think it promotes dignity because when we think about the history of harm reduction, where it came from, harm reduction really has the kind of understanding of nothing for us without us, and really ensuring that people who use drugs are at the table, that their voices are being heard, and they're not, we're not just doing kind of the tokenizing, like one person recovery at the advisory group meeting, but really ensuring that the decisions that are being made and the experts at the table are in fact people who use drugs. And to me, that's what I love about harm reduction as a concept and as a philosophy. Because it really does just emphasize that importance that people who use drugs have just as much to say, if not more, about issues like this.
Yeah, I feel like Zoe said it much more eloquently than I could, but I totally agree. And I think giving people voices like that in itself is, providing dignity. And that's what our research, that we're doing right now, and trying to have open conversations about discharging people home from the hospital, like what's safe, what's not safe, and really giving patients the voice to have a say in their own treatment plans, I feel like is also providing dignity, to patients.
Oh, this question that just came up in the chat?
Yeah, I was just going to do that one, but you go ahead, Zoe.
So what I'll say is that I wish that the syringes that were available in pharmacies and farm supply stores were appropriate for people to use for injection, because then we would have a little bit more access and availability, and especially in rural areas. Can you imagine if farm supply stores in Aroostook County carried clean syringes? The issue is that they're often not an appropriate type for this type of injection. So typically, syringe service programs carry insulin syringes in a variety of tip length and gauge. And most of the time in pharmacies, they only stock, they are still insulin syringes, but they tend to be a much smaller type. That just makes it very difficult for somebody, especially somebody who's regularly injecting and has built up scar tissue. And then when it comes to farm supply, those are often intramuscular syringes, which would not be appropriate for the majority of the people who are injecting drugs. We want to make sure that we're not just promoting clean syringes, but the appropriate types of supplies that are best suited for people, because we want to reduce infections and scar tissue and everything else that can come along with that. But it's a great question.
Elise, do you want to ask another question from the chat? Do we have any more from the chat, or is that the only?
Well, Kinna answered a question about how to approach harm reduction in like an attending setting. Kinna, I don't know if you would like to respond to that verbally as well, or if anybody else has any other questions, but that was in the chat.
Yeah, no, and I think that was a great question. And please, and if anyone else wants to chime in, but I totally understand that. It can be really awkward to say something to who's more senior than you, and I think, even if people don't feel comfortable doing that one-on-one, like I said, I think even if you offered to be like, hey, with every rotation, you can give a little educational talk, right? You can make your talk on stigma and substance use. And, I'm constantly calling out my own colleagues on these things, and we've sort of, they get it now. And I think it's just, I'd say just, feel empowered really to say something, whether it's to a senior resident or you're attending, or again, just through an educational training.
I think you can also, I'm usually the type that would not say something because it can be really nerve wracking. What I try to do in situations like that is extra model, just make sure I'm really using words a lot, talking about it a lot, and trying to really just model the language that we want other people to use. Because I do think that we also want to be careful that we're not making somebody else feel bad if they just don't know. And so really modeling the way we want those individuals to treat our patients is really kind of the same thing, by trying not to make them feel bad if they don't know. I think, there are a lot of new terms, and a lot of people just aren't aware of it if they're not familiar, and that's okay. So I think sometimes, even having there's so many what to say, what not to say little tables that you can print out and put on the refrigerator, or, I think that can be useful too.
Yeah, I think especially in group settings, that's what we'll do at our infectious disease directors meeting, or, colleague meeting. We'll say, remember, these are the terms that we should be using in our notes, and so no one's pointed out.
Right.
I'm curious about the progress made within law enforcement, Bob. I mean, you've got a hard audience, and I'd really be interested to hear what's going on statewide regarding law enforcement.
Absolutely. It is a hard audience, law enforcement goes back way back and they're set in their ways, right? And not to say that the academy teaches this, but just by virtue of the way that police academies teach across the country, it adds to that. It really begins that stigma, because they teach you that you're arresting the bad guy. You're the good guy and they're the bad guy. And if they're using drugs, they're the bad guy, right? So it all goes downhill from there. There's been a lot of movement in law enforcement, not only in Maine, but across the country. There's still work to be done. But in the state of Maine, I chair a committee at the Maine Criminal Justice Academy that recommends the mandatory trainings for all officers in the state of Maine, that the mandatory training that we have to take yearly. And I was fortunate enough just last year to get past a class on substance use disorder. And so I think I called it law enforcement's response to substance use disorder, because it kind of sounded kind of cool, right? Kind of catchy. You have to think about this. We're reaching officers across the state, all the way from, down south to northern Maine and in western Maine. So it's a large audience. It was more of an introduction to substance use disorder, but also bringing in that human element and changing the language and the way you treat people. I will also say that law enforcement executives, they are buying into it. They have been buying into it. At one point, several years ago, I felt kind of was alone, kind of at the top, until I went to a what's called PARI down in Massachusetts, where it's a convention of law enforcement executives across the country, LAPD, NYPD. And when I went there, I felt like I was home, because they're all speaking my language. I'm like, oh my God, I'm not weird. I am doing the right thing, and I will continue to do the right thing and continue to bring it more to Maine. There is a change across the country, and that will continue. It's not going to change. We can't change Rome in a day. I wish we could, because we'd have more lives we could save. But we will right the ship. And I say that's the same with the medical community too. You have docs that were taught old school back in the day that may not change their minds. But I look at everybody here today that's going to be in healthcare profession one way or the other, that are being trained. And I mean, they've already said so much. I'm impressed with what I've heard thus far. That's going to make a big difference moving forward. So it's going to get better. It's just going to take some time.
So I lost track of time. Sorry. I'm now inviting our panelists to give us your final words. I don't know, Bob, if that was your final say.
I'll go with that to save a minute. Sure.
Yeah. Kinna and Zoe, final takeaways.
Yeah, I would just say, there is a lot happening right now around recovery and harm reduction advocacy work in Maine. So if you're interested in contributing or sharing your voice, there's some really great resources. The Maine Recovery Advocacy Project, which I know Elise can make sure everyone has access to, can kind of fill you in on what we're working on. But I too am really impressed. I mean, I've been doing these Harm Reduction 101 sessions for several years now to students, and it's really incredible to see such a shift in the way people are talking and approaching this issue. So thanks so much for having me today.
Yeah, I agree. I'm just so impressed as well. And I think it's just very cool that UNE, has this type of training, and it's just really encouraging. And I think, like Zoe said, I think the strength we have here in Maine is our community organizations. And like she said, I think just reaching out to them, volunteering, shadowing, learning from people, I think that's the best way to get involved. And there's so many advocacy issues to get involved with. And you as students also have a voice, like people want someone yesterday just testified who was a medical student to provide testimony on loosening syringe service program restrictions. And so, I think as students, faculty, we all have a voice. So thanks for having me here, and feel free to contact me, if anyone has questions after this.
Thank you. Thank you so much. And we just have two last things before we close for today. One is to remind you that we do have counseling services here if you need to talk with someone. This was a very rich, emotional, and informational session. So here are the numbers here if you need to check in with someone. And don't hesitate to ask. Asking for help is a really important first step. And it's a resilient step in asking for help. And then finally, these are our next events that are going to be looking at aspects of harm reduction. On February 23rd, we're going to be looking at fetal alcohol spectrum disorder, a relatively invisible disorder that folks are going to be bringing us awareness. And then on Wednesday, March 2nd, we're going to be really looking at healthcare and aging in prisons. Talk about an invisible population that really needs us to be thinking about how we can do a better job helping people who are incarcerated. So I thank you all for being here. It was a wonderful hour and a half, and we're going to keep on doing this work, and we hope you'll join us. Thank you so much.